Hi guys, so today we're back with another video. Today I want to talk to you guys about cholinergic agonists. So cholinergic agonists are drugs that mimic the action of acetylcholine. They work by stimulating cholinergic receptors. So as we knew from last few lectures, there are two different types of cholinergic receptors. There's the muscarinic and the nicotinic. So these drugs can stimulate either the muscarinic or the nicotinic receptor, or both of them, if they are like non-selective. Alright, so I want you guys to hold on tight because there's quite a lot of stuff to cover. There's a lot of drugs that's going to be in this presentation. So I think the best way for me to make it easier for myself to explain this to you guys is to show you this map that I made. It's just to group the different drugs together so it's not too confusing. It might be confusing now, but we'll get back to this same slide once I finish explaining everything, and I promise you it's gonna make so much more sense, okay? So just hear me out. Okay, let's just get started. So cholinergic agonists. We have two different types based on how they work. So we have direct acting cholinergic agonists and we have indirect acting cholinergic agonists. So under the direct acting cholinergic agonist, we have two main types. So we have the natural alkaloids. So these are naturally occurring substances we find in nature, and the synthetic derivatives, which are, man-made basically. So natural alkaloids include acetylcholine itself, muscarine, pilocarpine, and nicotine. And the synthetic derivatives are carbachol and botanical. Okay? So under the indirect acting cholinergic agonists, there are two types. So we have the reversible agents and the irreversible indirect acting cholinergic agonists. So with the reversible ones, we have two different types. So there are drugs that are lipid soluble, which means that they can cross the blood-brain barrier and the corneal membrane, for example. And we have those ones that are just water soluble, so they don't penetrate the CNS in any way, okay? So the lipid-soluble ones include physostigmine, tacrin, galantine, donepezil, and rivastigmine. And the water-soluble ones are neostigmine, pyridostigmine, and trophonium. Right, so direct-acting cholinergic agonists are called direct-acting cholinergic agonists because they directly bind to the cholinergic receptors, mimicking the effect of acetylcholine. So as I mentioned from the previous slide, we have two types. We have the natural alkaloids and we have the synthetic derivatives. So in the natural alkaloids, we have acetylcholine, pilocarpine, nicotine, and other stuff that I mentioned like muscarine. But these are the main three ones I want to talk to you guys about today. And in the synthetic derivatives, today we're going to talk about botanical and carbachol. Alright, so let's start off firstly with nicotine. So nicotine only works on the nicotinic receptors. I should explain this table first. So I made this table just to make it so much simpler for me to explain this and for you guys to understand. So here we have the drug name and their spectrum of action, their selectivity, if they're selective to muscarinic receptors, nicotinic receptors, or both. And this one, it shows if the drug can be hydrolyzed by acetylcholinesterase or not. So yes or no. Here it shows you if it's lipid soluble, which means if it's yes, then it can cross the blood-brain barrier and elicit CNS effects, and no if it's just water soluble and doesn't penetrate the brain, the CNS. Duration of action, the clinical uses, if there's any, and the adverse effects and interactions of, the specific drugs that we're talking about. So let's get back to nicotine. So nicotine, as I was saying, it acts on the nicotinic receptors only. It cannot be hydrolyzed by acetylcholinesterase because it's not really an ester, so it's not a substrate of acetylcholinesterase. It can be inactivated by the liver, though. I think the metabolite is called cotinin. So basically, it can be inactivated by the liver, okay, but not by acetylcholinesterase. It is lipid soluble, it can cross the blood-brain barrier, and duration of action 4 to 6 hours. Usually it's administered or it's used as, a gum or a transdermal patch, and it's used to help people stop smoking. Adverse effects and interactions. So nicotine produces generalized ganglionic stimulation, and it elicits, hypertension via vasoconstriction and tachycardia, as well as, if there's severe overdose, we get convulsions, paralysis, and even coma. Right, guys, so moving on to the next two naturally occurring cholinergic agonists, we have acetylcholine and pilocarpine. Acetylcholine, as we know, it acts on both the muscarinic and the nicotinic receptors. And yes, it is hydrolyzed by acetylcholinesterase because it's an ester, but it's not lipid soluble, okay? Duration of action, very, very short, so only 5 to 30 seconds. And that's mainly because it's rapidly hydrolyzed by acetylcholinesterase. That's enzyme's favorite substrate. Clinical uses. So this is the thing, because acetylcholine is non-selective, and because of the fact that it's rapidly and easily hydrolyzed by acetylcholinesterase, I don't actually think there's any clinical uses of acetylcholine on its own, but we can discuss the effects of acetylcholine, which we've talked about in previous videos, but we'll go over them real quick in this video just to remind you guys. So acetylcholine can increase GI motility via the activation of the M3 receptor. So that's like increasing peristaltic activities and stuff in the intestines and the colon. It can also promote secretions via, again, the activation of M3 receptors. So it can increase lacrimal secretions, it can increase sweating, it can increase gastric secretions. Acetylcholine can also promote meiosis via, again, the activation of M3 receptors, and meiosis is simply the constriction of the pupils, okay? Acetylcholine also has an effect on the bronchioles. So the bronchular smooth muscles, they constrict when acetylcholine activates the M3 receptors. And with the bladder, it can increase urinary urgency by constricting the bladder wall and relaxing the sphincter muscles. Right, so next up we have pilocarpine. So pilocarpine, it's selective to muscarinic receptors, and it is not hydrolyzed by acetylcholinesterase because it's not an ester. It is lipid soluble, however. It can cross the blood-brain barrier and elicit CNS effects. It may actually activate EPSP, which is excitatory postsynaptic potential via M receptors in the ganglia. So duration of action, it's 30 minutes to 2 hours. Clinical uses. So there's mainly 3 clinical uses for pilocarpine. There's other things, but I'm listing the ones that are quite important for our exams. So the first one is the treatment of glaucoma. So pilocarpine is used in the treatment of glaucoma because it causes meiosis, which is pupillary constriction. So when meiosis happens, that decreases the intraocular pressure. Okay. So the next one is to treat patients with xerostomia. I don't know how to pronounce that correctly, but I think that's how you say it. So basically, it can increase, salivary secretions in patients with xerostomia. That basically means that these patients have dry mouth, mainly due to radiation, of the head and neck for like cancer therapies and stuff. And the next use is to increase, again, lacrimal and salivary secretions in patients with Sjogren's syndrome. I'm really bad at pronouncing, but yeah, so this is basically an autoimmune condition leading to dry mouth and eyes. So if we administer pilocarpine, then we could increase lacrimal, which is eye secretion, and alleviate the dry mouth by increasing salivary secretions. So adverse effects of the eye drops for glaucoma, it can cause blurred vision, brow ache, and night blindness. And just the adverse effects of pilocarpine in general, it can cause diaphoresis, which is excess sweating. It can also cause excess bronchial secretions, lacrimation, and salivation. And it can cause diarrhea because it could, overstimulate the GI tract, increase peristaltic activity, and make us poop more. Okay? Right, so now let's discuss the synthetic derivatives. So we're still under the direct acting cholinergic agonist. So these drugs are still directly acting on the cholinergic receptors, but they are synthetic. So these are not found in nature. They are made in the lab. Okay, so let's start with bethanechol. So bethanechol has selectivity for the muscarinic receptors, and it is not hydrolyzed by acetylcholinesterase because, again, it's not an ester. They are actually, I think, it has an ammonium salt and a carbamate ester. So, there's the ester part, but bethanechol is a poor substrate for acetylcholinesterase, but because it has that carbamate ester bit on it, it can be inactivated through hydrolysis by other esterases, just not acetylcholinesterase, okay? So for the simplicity, it is not hydrolyzed by acetylcholinesterase, but it can be inactivated by other esterases, okay? It is not lipid soluble. The duration is about 30 minutes to 2 hours. It's mainly used for two things. Again, there's a lot of other uses, but I'm just summarizing the main ones. So it is used primarily for the athernia of the bladder. So you give bethanechol if the bladder is not working, if it's not constricting for some reasons, to increase the urinary urgency of that patient, okay, to basically resolve the athernia of the bladder. Again, it is used for megacolon. So you know how bethanechol can increase peristaltic activity via activating M3 receptors. So megacolon is a condition where the colon is dilated, but it's not due to obstruction. And this is usually accompanied by the paralysis and peristalsis. So if you give bethanechol, you increase the peristaltic activity and you resolve this situation, basically, okay? So the adverse effects include increase in urinary urgency, diarrhea, diaphoresis, vasodilation, which can then lead to reflex tachycardia, because if our vessels vasodilate, that causes a drop in blood pressure, and our heart tries to compensate by basically increasing our heart rate. So that's called reflex tachycardia. It can also cause the redness and flushing of the skin. Right, so carbachol, on the other hand, it acts on both the muscarinic and nicotinic receptors, so it is non-selective. Again, it's not hydrolyzed by acetylcholinesterase, and it is not lipid soluble either. And duration of action, same with bethanechol, 30 minutes to 2 hours. And clinical uses, I put glaucoma. It's used as, a miotic agent, again, because it promotes pupillary contraction, which decreases intraocular pressure. But it is rarely used because, it's non-selective, and it actually has high potency as well. So it's usually not used for anything else. So adverse effects, it's basically the same as bethanechol. So it increases urinary urgency, diarrhea, diaphoresis, vasodilation, and redness and flushing of the skin. Right, so we've discussed the directly acting cholinergic agonists. So now let's move on to the indirectly acting cholinergic agonists. So these drugs, they amplify the effects of endogenous acetylcholine by inhibiting the acetylcholinesterase, which means that we're increasing the concentration of acetylcholine, in our body, because it's not being broken down by acetylcholinesterase. They're called indirectly acting because they don't really interact with the acetylcholine receptor, but instead they inhibit the enzyme that is responsible for the breakdown of acetylcholine. Okay, so we have two types. We have the reversible type and we have the irreversible, the indirectly acting cholinergic agonists. So in the reversible ones, we have the lipid-soluble agents and we have water-soluble agents. So these lipid-soluble agents or drugs, they can cross the blood-brain barrier, and the water-soluble ones, they cannot penetrate the CNS, okay? So examples of lipid-soluble, reversible, indirectly acting cholinergic agonists are physostigmine, rivastigmine, galantamine, cacrin, and donepezil, okay? And the water-soluble ones are edrophonium, neostigmine, and pyridostigmine. So the irreversible ones, so these ones, they usually bind to the enzyme via covalent bonds. So, you know, that's really strong bonds. That's why they are irreversible. So we have two main subclasses. We have the organophosphates, like parathion and malathion. And we have the really toxic and lethal nerve gases, such as sarin and tabun. Alright, so let's start with the reversible cholinergic agonists that are water soluble. So these guys, they cannot cross the blood-brain barrier, so they will not elicit any CNS effects, but they are reversible, so the effects of these drugs can be reversed, okay? So it's not the end of the world. If they bind to acetylcholinesterase, they can come off from those enzymes, okay? So the first one that I want to discuss is edrophonium. So again, okay, let's just explain this table because it's a different table that I made. So here we have the name of the drug, and here we have the type of compound. It's not too important, but I like chemistry, so I'm just putting that in. I don't think we need to know this for the exams. And the duration of action of these drugs, and their clinical uses, which we do have to know for exams, and the adverse effects and interactions of the drugs, okay, with other drugs. Okay, so let's go back to edrophonium. Edrophonium is a quaternary alcohol, okay, so it has the duration of 5 to 10 minutes, so not very long acting at all, and it is mainly used for the diagnosis of myasthenia gravis, okay. So it is also used to differentiate between myasthenic crisis and cholinergic crisis. Because if you give edrophonium to a patient and their muscle strength increases, then that points towards myasthenic crisis instead of a cholinergic crisis. I just want to explain why it's kind of short-lived. So it's short-lived because the drug only makes very weak electrostatic and hydrogen bonds with the enzyme. So there's, you know, no kind of permanent bonding with the enzyme. That's why the duration of action it's very, you know, short. And adverse effects. So edrophonium increases, you know, all parasympathetic effects. So this includes increased peristaltic activity, which can then result to vomiting, diarrhea, stomach pain, and feeling nauseous. It could also increase urinary urgency and lacrimation. Moving on to neostigmine. So neostigmine has a carbamate group that can form reversible covalent bonds with acetylcholinesterase. So this time the duration of action is quite, you know, is significantly longer than edrophonium. So duration of action is between 2 to 4 hours. So it's mainly used for a couple of things that I've listed here. The first one is for the treatment of myasthenia gravis. And the second one is the reversal of the nicotinic M type of receptor. If it's blocked, for example, due to cobra bite. So cobra bite, you know, it has a venom, it has a neurotoxin that can paralyze muscles, including like respiratory muscles. And sometimes neostigmine is given to these patients that have been bitten by cobras to stimulate the NM receptors again and resolve this paralysis, okay, to reverse this paralysis induced by the neurotoxin. The other use could be for post-operative paralytic ileus. So that just means, you know, after surgery, especially like, you know, surgery in the GI tract, due to general anesthesia and just due to, you know, just the surgery on its own, the GI motility can be impaired after the surgery. So this impairment of the GI motility post-surgery is called post-paralytic ileus, and we can give neostigmine to stimulate the GI tract and increase the motility and peristaltic activity in the GI tract and resolve this problem. The last use could be for the atonia of the bladder. So again, we give neostigmine to constrict the bladder walls and increase urinary urgency. Adverse effects are basically similar to edrophonium. So the last type of indirect acting cholinergic agonist that's water-soluble is pyridostigmine. So pyridostigmine, again, it has that carbamate group that can form reversible covalent bonds with acetylcholinesterase, which is why the duration of action is quite longer than that of edrophonium. So pyridostigmine is mainly used for treatment of myasthenia gravis, and the adverse effects are similar to that of edrophonium, but obviously with longer duration. Right, so now let's discuss the lipid-soluble, reversible, indirect acting cholinergic agonists. So, as I kept saying, these lipid-soluble agents can cross the blood-brain barrier and elicit CNS effects, okay? So first up, we have physostigmine. Again, it's a carbamate with a duration of action of 2 to 4 hours. And it's mainly used to reverse atropine poisoning. Atropine is an anticholinergic drug, which we will discuss in future videos. But for now, just remember physostigmine is used to reverse the effects of anticholinergic drugs such as atropine, okay? And the second use, it is used to treat acute glaucoma. So it can be applied topically because, you know, it can cross corneal membranes as well. Because it's lipid soluble, it can cross corneal membranes and it can be applied topically to treat acute glaucoma. So it's a very good meiotic agent, which means that, again, it constricts the pupil, which decreases intraocular pressure, and therefore a good drug for treatment of glaucoma. Adverse events similar to edrophonium, again, and because it can cross the CNS, it can have CNS effects such as seizures if you overdose on physostigmine. So not a good idea, okay? Okay, the next group of drugs, I grouped them together because they kind of have similar clinical uses. So we have rivastigmine, galantamine, tacrine, donepezil. Don't bother about the type of compounds for each one of these drugs, it's not relevant. Duration of action, so they have a half-life of between 1.5 to 70 hours. I know it's a big range, it's because there's 4 different types of drugs here and I can't be bothered to put the duration of action for every single one, so I just put like everything, okay? Clinical use, mainly to treat mild to moderate Alzheimer's and Parkinson's. Apologies for my spelling, that should say Parkinson's, not Parkinson's, okay? So these agents are used to treat mild to moderate Alzheimer's and Parkinson's. Adverse effects include nausea and vomiting. Now moving on to the really serious drugs, the irreversible indirect acting cholinergic agonists. So these guys bind to acetylcholinesterase irreversibly, okay? So the first group of compounds are called organophosphates. So first up we have parathion. Parathion is an organophosphate that covalently binds to acetylcholinesterase, which means that the duration of action is long. We're talking days to weeks here, guys. Days to weeks. Clinical uses, practically none. It's only used as an insecticide, okay? if you use that for a person, then that person can die. It's literally very lethal. So adverse effects, as I was saying, really lethal. It causes all parasympathetic effects. It's highly dangerous, okay? So the easiest way to remember the parasympathetic effects that are caused by parathion poisoning is with this acronym, dumbbells, but it's double E, one L, and double S, so not the traditional spelling of dumbbells. But anyway, D for diarrhea, U for urination, M for meiosis, a B for bronchoconstriction or bronchospasm, and it also increases bronchosecretions. Parathion could lead to bradycardia, excitation of skeletal muscles in the CNS, emesis, which is vomiting, L for lacrimation, S for salivation, and another S for sweating. So in addition to those effects, because it can cross the blood-brain barrier, it can cause, coma as well in very, very, very high doses, okay? So another example of an irreversible indirect acting cholinergic agonist that's lipid soluble is malathion. Again, duration of action can be days, okay? Clinical uses practically, again, none. It's mainly used as an insecticide only, but I have consulted Google, and Google told me that it's being used, or it has been used, I'm not sure, as a scabicide topically, and to kill head lice. Not sure how effective, but Google said that those are some of the uses of malathion. Adverse effects. In general, it's a much safer insecticide than parathion. However, it is still rarely used because the absorption of malathion readily results to the metabolism to a compound called malaoxone, which is 61 times more toxic than malathion itself. So it's still not good. Okay, so enzyme regenerators called oximes can be used for organophosphate poisoning, but contraindicated for carbamate poisoning. Okay, let me explain this picture as well that I've made for you guys. So remember how I said that organophosphates such as parathion and malathion, they covalently bind to acetylcholinesterase, right? But luckily we have these agents called enzyme regenerators or enzyme reactivators called oximes. For example, pralidoxim is an example of an enzyme regenerator. They can be used for organophosphate poisoning, but contraindicated for carbamate poisoning. Okay, I'll explain that in a little bit. But there's a condition. If you're gonna use pralidoxim to reactivate acetylcoenzyme esterase, it must be given before the aging of the enzyme. Aging just means before there are profound conformational changes to the enzyme, to the point where those changes can no longer be reversed. Okay, so it has to be given before that profound conformational change to the enzyme. Okay, and pralidoxim, it's not lipid soluble, unfortunately, so it cannot penetrate the brain, or it cannot cross the blood-brain barrier. Therefore, it cannot reverse any CNS effects that's been induced by the organophosphate poisoning. Other supported measures that we can use is maybe giving atropine as an antidote, maybe giving diazepam as well as a muscle relaxant to, dampen down the convulsions, and give oxygen supply as well to maintain that patent airway, because, we talked about bronchoconstriction and bronchospasm as an adverse effect of organophosphate poisoning. So giving oxygen can definitely help. Right, so now let's try understand this picture that I've drawn here. So acetylcholinesterase, the enzyme, it has two sites. So we have the anionic site and esteratic site. So enzyme regenerators are contraindicated for carbamate poisoning, but can be used for organophosphate poisoning because of this exact reason. If you look here, the organophosphate binds to the esteratic site of the enzyme, whereas the actual oxime binds to the anionic site of the enzyme, which reactivates the enzyme, okay? But carbamates, these guys, they bind to both the anionic and esteratic site, which means that oximes cannot replace them and reactivate acetyl coenzyme esterase. Alright guys, so I hope you're still awake, and if you've made it this far to the video, well done. Thank you for listening. So now we're going to talk about the last group of irreversible indirect acting cholinergic agonists, which are the nerve gases. So these bad boys are really lethal. So examples include tabuin and sarin. So they are both nerve gases, and as we said, they are lipid soluble, so they are really scary because they can cross the blood-brain barrier. Duration of action days to weeks, and in fact they act more rapidly than parathion, so they bind to that acetylcholinesterase much more rapidly than any of the organophosphates, okay, that we've mentioned before, like parathion and malathion. Clinical uses, none, okay? These guys are nerve gases. Maybe if you want to kill an army, then go ahead and use it, but clinically, there's no use for them. Adverse effects, lethal, deadly, never use, okay? Also, I don't think there are any antidotes or any agents that could reverse the effects of these nerve gases. I'm not sure, but I don't think there are any, so very scary drugs. Okay, just to summarize, I'm going to show you this slide again as I promised in the beginning of the video. So cholinergic agonists, we have two types, which you should know by now. We have direct acting and indirect acting. Direct acting cholinergic agonists are called direct acting cholinergic agonists because they interact directly with the cholinergic receptor. They mimic the effects of acetylcholine, whereas indirect acting, they don't bother with the receptor. They inhibit the action of acetylcholinesterase, thereby preventing the breakdown of acetylcholine, making acetylcholine, the concentration of them increase, and therefore increasing their action. So direct acting, we have the natural alkaloids such as acetylcholine, muscarine, pilocarpine, and nicotine. Synthetic derivatives are carbachol and bethanachol. So in the indirect acting, we have the reversible and irreversible agents. So reversible, we have the lipid-soluble drugs, and then we have the water-soluble drugs. And irreversible, we have the organophosphates and the nerve gases. I hope that all makes sense. If you have any questions whatsoever, please type in the comment section below. I hope you've enjoyed this video. I hope you've learned from it, and I hope it helps you with the revision. So good luck with the revision. We can all do this, future doctors, and I wish you all the best for our exams.